To carry on with the upper limb lectures, I'm going to discuss in this presentation the nerves of the upper limb. I'm Dr. Dalia Saleh, Professor and Head of Anatomy Department at Mansoura University, Egypt. The objectives of my presentation are: first, I will discuss the anatomy of the brachial plexus regarding its formation and branches. Then I'm going to focus on 5 of its main branches, which are the musculocutaneous, the axillary, the radial, the median, and the ulnar nerves. I'm also going to discuss the distribution of the branches of the brachial plexus and the effect of its injuries. At the beginning, we should know what is the definition of the nerve plexuses. At the level of the upper limb and lower limb, the ventral rami of the spinal nerves communicate together and form a network into which their nerve fibers are exchanged together. The resulting branches of this network possess fibers derived from different spinal nerves. So at the root of the upper limb we have the brachial plexus, while at the root of the lower limb we have the lumbosacral plexus. So from the brachial plexus all the nerves supplying the upper limb will arise, while from the lumbosacral plexus all the nerves that will supply the lower limb will arise. The brachial plexus is formed of 5 roots from the ventral rami of C5, C6, C7, C8, and T1. These roots will unite together to form 3 trunks. So we have the upper trunk made by union between C5 and C6, middle trunk made by C7, and lower trunk made by C8 and T1. Then these trunks will give us 6 divisions. So we have 3 anterior divisions that will finally supply the front of the upper limb, and 3 posterior divisions that will supply the back. Then the next stage in the formation of the brachial plexus, we have 3 cords arise from the anterior and the posterior divisions. We have the lateral cord is made by the fusion of the anterior divisions of both the upper and middle trunks. We have a medial cord made by the anterior division of the lower trunk, and a posterior cord made by the union of all the 3 posterior divisions. So again, the stages of formation of the brachial plexus, we have the roots from C5 up to T1. The trunks, we have upper, middle, and the lower trunks. And then the divisions, we have 3 anterior divisions and 3 posterior divisions. And then the cords, we have 3 cords: lateral cord, medial cord, and posterior cord, arranged around the axillary artery in the same direction: lateral to the axillary artery, medial to the axillary artery, and posterior to the axillary artery. What are the branches of the brachial plexus? From the roots, we have the dorsal scapular nerve that arises from C5. It descends backwards and supplies the muscles attached to the medial border of the scapula. We have the levator scapulae and rhomboides minor and major. Also, we have the long thoracic nerve that arises from both C5, 6, and 7. It descends on the side of the chest and supplies the serratus anterior muscle. Then we have the trunks of the brachial plexus. From the upper trunk, we have nerve 2 subclavius, which arises from C5 and C6 roots that will supply the subclavius muscle. We also have the suprascapular nerve, also arises from the upper trunk from C5 and 6 roots. It will supply both the supraspinatus and infraspinatus muscles. From the divisions of the brachial plexus, no branches arise, while from the cords of the brachial plexus we have 13 branches. 3 from the lateral cord, 5 from the medial cord and 5 from the posterior cord. The 3 branches that arise from the lateral cord of the brachial plexus are the lateral pectoral nerve for the pectoralis major muscle, the lateral root of median nerve that will share in the formation of the median nerve itself, and the musculocutaneous nerve that will supply the muscles at the front of the arm. From the medial cord, we have 5 branches. We have the medial pectoral nerve for the pectoralis major and minor muscles, the medial root of median nerve, which will share in the formation of the median nerve, the medial cutaneous nerve of the arm and the forearm, and they will supply the skin at the medial side of the arm and the forearm respectively, and of course the ulnar nerve. And we have 5 branches from the posterior cord of the brachial plexus. They are the upper and lower subscapular nerves, the thoracodorsal nerve, the axillary nerve, and the radial nerve. The upper and lower subscapular nerves will supply the subscapularis and the teres major muscles, while the thoracodorsal nerve, which is also called nerve 2 latissimus dorsi, will supply the latissimus dorsi muscle. Regarding the injuries of the brachial plexus, we have 2 types of injuries, either traction injury, as in birth injury, when the obstetrician extended the neck of the baby in a way that will make a traction on the brachial plexus, or in motor car accidents or motorcycle accidents when the neck is overextended to one side. The other type of injury of the brachial plexus is due to compression by a cervical rib, for example, if there is an accessory cervical rib that will compress over the roots of the brachial plexus. Also, if there is direct injury, as in stab wounds. If the lesion is at the upper trunk of the brachial plexus, we call it herpes palsy. In this case, the upper trunk is affected, or the roots C5 and 6 are affected, so the patient cannot elevate his shoulders, flex his elbow, or turn his arm outside. So the patient will end up with depression of the shoulder, extension of the elbow, and medial rotation of the upper limb. If the lesion of the brachial plexus at its lower trunk, we call it Klumpke's palsy. In this case, C8 and T1 are affected, and these nerve roots are responsible for supplying the muscles of the hand, so the hand is weak with no grasp. The patient will have what is called claw hand deformity, and the patient cannot move his fingers, and also it is accompanied by sensory loss from the medial side of the upper limb. Now we will talk in details about the 5 main branches of the brachial plexus. I will start first with the musculocutaneous nerve. It arises from the lateral cord of the brachial plexus. It contains C5, 6, and 7 nerve roots. It leaves the axilla by piercing the coracobrachialis muscle, then passes downward in the arm beneath the biceps muscle. It ends at its lateral border as the lateral cutaneous nerve of the forearm and supplies the anterior compartment muscles, namely the coracobrachialis, the biceps brachii, and the brachialis muscle. Also, it will supply the lateral side of the skin of the forearm. Next, we have the median nerve. It is formed by 2 roots, one from the lateral cord and one from the medial cord of the brachial plexus. So it contains all the 5 nerve roots from C5 till T1. It descends in front of the axillary artery, then crosses the brachial artery from lateral to medial. It enters the cubital fossa medial to the brachial artery and leaves it between the 2 heads of the pronator teres muscle. And then it descends in the forearm then passes through the carpal tunnel under the flexor retinaculum into the hand. And remember that it is a dangerous position for the median nerve because it could be compressed here. It has no branches at the axilla or the arm or at the cubital fossa. It starts to give its branches at the forearm, so it has motor branches to the all muscles of the anterior compartment of the forearm except the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. It also has motor branches in the hand. We will remember the muscle that's supplied by the median nerve by the word loaf. So it supplies the lateral two lumbricals, the opponent's pollicis, the abductor pollicis, and the flexor pollicis. It has also sensory branches to the skin over the thinner eminence, the lateral two-thirds of the palm of the hand, and the palmar aspect of the lateral 3½ fingers. The injury of the median nerve could be due to supracondylar fractures of the humerus, stab wounds at the cubital fossa, or at the forearm or at the wrist, so there is direct injury to the median nerve itself, deep wrist lacerations, and also if there is compression of the median nerve at the carpal tunnel. We call it the carpal tunnel syndrome. There will be wasting of the anterior compartment of the forearm muscles and also at the thinner eminence muscles. We call this deformity the ape hand deformity. The patient cannot flex their index or middle fingers, and this results in unopposed extension of these two fingers. For the ulnar nerve, it arises from the medial cord of the brachial plexus, and it is the largest branch of the medial cord. It contains C8 and T1 nerve fibers. It lies medial to the axillary and the brachial arteries along its course. Then it pierces the medial intermuscular septum of the arm to pass behind the medial epicondyle of the humerus. And this is a dangerous position because it could be compressed against this bony eminence. Then it enters the forearm between the two heads of the flexor carpi ulnaris, and then get into the hand in front of the flexor retinaculum. It lies superficial to the flexor retinaculum, but only covered by a fascial sling from it. After entering the hand, it divides into superficial and deep divisions. The ulnar nerve also does not give any branches in the axilla, arm, or at the cubital fossa. Then it starts to give its branches at the forearm and hand. In the forearm, it gives motor fibers to two muscles there in the anterior compartment of the forearm. They are the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Then, at the hand, it supplies all the intrinsic muscles of the hand. We will remember them by the word hela, since it will supply the muscles of the hypothenar eminence, the interossei, the medial two lumbricals, and the adductor pollicis. Also, it gives the sensory branches to the medial third of the palm and the dorsum of the hand, and also to the palmar and dorsal aspect of the lateral 1½ fingers. Injuries of the ulnar nerve may be due to supracondylar fractures of the humerus, fractures of the medial epicondyle because it passes just behind it, direct injury by stab wounds in the forearm or at the wrist. Also, there could be compression of the nerve either at the cubital tunnel while it passes between the two heads of the flexor carpi ulnaris, or while it passes superficial to the flexor retinaculum but covered by a fascial sling. We call it the Guyon's canal. The injury of the ulnar nerve is presented as follows. There will be wasting of the hypothenar eminence and the intrinsic muscles of the hand. So here we can see there is wasting and atrophy at the intermetacarpal spaces, especially at the first intermetacarpal space. And the deformity here will be claw hand deformity. It appears both at rest and exaggerates when the patient tries to extend his fingers. In ulnar nerve injuries, the patient cannot extend the interphalangeal joints of their ring and little fingers. The axillary nerve is one of the branches of the posterior cord of the brachial plexus. It has C5 and C6 nerve fibers. It passes beneath the shoulder joint through the quadrangular space, accompanied by the posterior circumflex humeral artery. Then it wraps around the surgical neck of the humerus together with the same artery, the posterior circumflex humeral artery. The axillary nerve has motor fibers to the deltoid and the teres minor muscles, and also has sensory fibers to the skin over the lower part of the deltoid muscle. The injuries of the axillary nerve could be due to fracture of the surgical neck of the humerus, and also could be injured by direct stab wounds to the posterior part of the shoulder. It also could be injured if there is anterior shoulder dislocation, so the dislocated head of the humerus could directly cause injury to the axillary nerve. It could also be injured by pressure of the crotches at the armpits. They call it crotch palsy. In this picture, we can compare the left deltoid with the right deltoid. So there is wasting of the deltoid muscle on the right side, making the bones of the shoulder joint very prominent and obvious. And we also can see that the shoulder appear adducted and medially rotated. Finally, we will discuss the radial nerve. It is the largest branch of the posterior cord of the brachial plexus, so it contains all the fibers that form the brachial plexus from C5 till T1. It runs behind the axillary artery, then it passes on the spiral groove at the back of the humerus between the lateral and medial heads of the triceps, accompanied by the profunda brachii artery. It enters the cubital fossa in front of the lateral epicondyle. Then it gives two terminal branches, a superficial branch which is mainly sensory to end at the dorsum of the hand, and another deep branch which is mainly motor that pierces the supinator muscles and descends along the posterior surface of the interosseous membrane, accompanied by the posterior interosseous artery. And for the distribution of the radial nerve, it has motor fibers to the posterior compartment of the arm, namely the triceps muscle. Also to the posterior compartment of the forearm. It also gives sensory branches to the posterior aspect of the arm and the forearm, and to the lateral 2/3 of the dorsum of the hand, and to the proximal part of the dorsal aspect of the lateral 3½ fingers. The injury of the radial nerve could be due to fracture of the humerus, since it passes in the spiral groove. Also, if there is direct stab wounds to the cubital fossa at the forearm or at the wrist, and also it could be compressed by crutches on the armpits. We call it crotch palsy. The injuries of the radial nerve is manifested by the following. There will be wasting of the triceps and the posterior compartment muscles of the forearm, and the deformity is called wrist drop, since the patient cannot extend his wrist, and on attempting to do this, the wrist will drop back. The forearm is also pronated due to paralysis of the supinator, and the fingers are flexed and the thumb is adducted. This will be the end of my presentation. Thanks for listening. If you like it, please do not forget to subscribe, like, and share, and do not forget to hit the notification bell so you know if I upload another video. Please feel free to leave a comment below. See you in the next video. Thank you.